The hip joint is based around the articulation between the acetabulum of the hip bone, which contains the symphysis between the three hip bones. Its two parts are known as the outer lunate surface and the inner acetabular fossa, which is the depression on the inside. And the other part of the hip joint is the head of the femur. The femur is made up of a shaft with a greater and lesser trochanter, an intratrochanteric line, neck and head. Just behind the greater tubercle, or greater trochanter, is the trochanteric fossa and the quadrate tubercle, and on the inside of the head is the fovea, which is just a little depression in the middle, which gives rise to the ligamentum teres, or round ligament of the femur. The normal angle of the hip joint is said to be 125 degrees, and this is inclination. So the neck is angled 125 degrees upward from the shaft. The angle is slightly smaller in females to allow wider hips, and the angle also decreases through life, going from 160 degrees in a newborn to 120 in an elderly patient. An abnormally low angle is called a coxa vara, and a high one a coxa valga. The other angle of importance is the angle of anteversion, and that's the angling of the neck around 12 degrees forwards, pushing the centre of gravity forwards with it, ideal for proper balance. So the long femoral neck pushes the shaft of the femur laterally, although the distal end of the femur, the head of the femur, needs to lie underneath the hip joint to support the body's weight fully. But pushing the rest of the leg laterally allows for a wider range of movement. So this is why the shaft of the femur is slightly angled, known as the anatomical axis. The mechanical axis of rotation is the angle between the head at one end and the joint with the knee at the other end. Muscles operating around this axis. Under X-ray, the hip joint would show a space which is filled with articular cartilage that you can't see on a plain X-ray. And the width of this space can be used to assess the state of the cartilage itself. A reduced joint space might be one of the first signs of arthritis. It's also dependent on the position the patient was in, either standing or supine. And the limb can be rotated to see the different trochanters. So it must be externally rotated towards the back to see the lesser trochanter. Otherwise you'll see the greater trochanter in a normal position. To look for a break in the bone, you can look along Shenton's line, which goes from here all the way along the neck of the head of the femur, onto the inferior ridge of the superior pubic ramus. Just to reconsider the acetabulum, the inferior border is covered by the transverse acetabular ligament, with a little gap inside called the acetabular foramen. So that's just a gap under the ligament. This external ridge is the labrum, and the lunate surface is the bit on the inside. So it's important to learn all of these because they're the attachments for the joint capsule of the head of the femur, although the head itself doesn't actually sit in the synovial cavity but just outside it. So there's the synovium between all of these structures and the head of the femur. And also know that the acetabular foramen is the route for the obturator artery. The labrum provides a ring of cartilage which deepens the joint socket more than it would be in just the bone. Dislocations often involve rupture of this labrum. The connection inside is made by, as I've said, the ligamentum teres, or also known as the ligament of the head of the femur. On the femur bone itself, the joint capsule is attached to the intratrochanteric line. There are three capsular ligaments of the hip joint capsule. The iliofemoral ligament is probably one of the strongest ligaments in the body, attached to the iliac margins of the acetabular labrum. extending proximally to the ASIS, anterior superior iliac spine, and distally, i.e. on the head of the femur, to the intratrochanteric line, greater and lesser trochanters. The pubofemoral ligament arises from the pubic margin of the acetabulum and superior ramus of the pubis, and inserts onto the lesser trochanter. And the ischiofemoral ligament, which is the final one, arises from the ischial margin of the acetabulum, behind the bit that we can see here, the ischial margin. This is the ischial margin, but if you imagine from a posterior view, it inserts into the iliofemoral ligament, which is the one, remember, coming across here, and partly into the greater trochanter. This ligament pinches the joint capsule around the head of the femur, the function of the ligaments being to prevent dislocation and reinforce the hip joint, with the ischiofemoral ligament contributing to the structure called the zona orbicularis, or circular ligament. The ischiofemoral ligament limits medial rotation of the hip. The pubofemoral ligament limits, imagine that it's keeping the hip joint quite close to the pubis, preventing it from being flexed, rotated backwards and outwards. So along with the greater trochanter, also preventing some abduction and extension, again stopping the hip from moving too far out. And in the case of limiting extension, it's also assisted by the iliofemoral ligaments. The blood supply to the hip comes from the cruciate anastomoses around the level of the lesser trochanter and in the shape of a cross, and this is branches from the thigh and from the inferior gluteal artery at the back. Branches running down the neck of the femur drag some of the synovium into little branches and folds called retinaculae. And this is the level of the greater trochanter, where the trochanteric anastomosis is located, between the circumflex femoral artery and a descending branch from the superior gluteal artery. A fracture of the femoral head and neck may lead to the rupture of these retinaculae, resulting in avascular necrosis of the head, leading to severe joint problems. And this happens in the case of a fracture of the neck, which is called a cervical fracture, or immediately below the head, a subcapital fracture. But if you get a more distal fracture, such as an intratrochanteric fracture, the retinaculae will be spared, meaning the condition is unlikely. Avascular necrosis is a complication of up to 80% of hip fractures and dislocations, and can be seen on an X-ray as a white area, through a shadow on a white density X-ray, or a dark area on an MRI. It can also be seen when the patient takes a radio-labelled isotope, in that the non-metabolically active area doesn't take up much of the isotope from the blood, and therefore the necrosis is visible.